Good afternoon, everyone. Thanks so much, Kristen and Elderwerks, for having me here to present on this topic. I'm Danielle Dodson. I'm a clinical social worker and program coordinator at the Advocate Memory Center based at Lutheran General Hospital in Park Ridge. And I'm going to talk today about advocating for your loved one with dementia in the healthcare system. This is a big topic, so it will not be an exhaustive presentation, but hopefully a starting point to understand some of the challenges that may arise and strategies and resources to help you through those challenges. So this is the team that I am fortunate enough to work with at Advocate. We do have sites in multiple locations throughout the Chicagoland area, Park Ridge, the far south side of Chicago, and Downers Grove, where our medical providers see and evaluate patients who have had cognitive changes and provide ongoing outpatient care. We do have another nurse practitioner since this flyer was made. So our team is growing. And please feel free to reach out if you're looking for a care provider for a loved one. So what we'll talk about today, before we dive into the various healthcare and service settings that you might encounter, we're going to talk a little bit just about sort of a Dementia 101, just to make sure we're on the same page and understanding what are we here to talk about today. And then we'll talk about advanced care planning to be prepared to advocate and navigate in these other care settings. We'll talk about getting in the door, getting a diagnosis, and then move on to different types of services you might try to put in place, including home and community-based services, hospitalizations that may be encountered throughout the disease course, perhaps transition to residential care, and then palliative and end-of-life care. So we'll really go through the disease trajectory and just try to touch on some key points at each stage in this process. Because dementias are progressive conditions, the role of a caregiver changes and tends to grow over time. And so we'll look at those different kind of points in time and points in the disease process. So again, you're going to start with a quick Dementia 101 because knowledge is power, and the way that you can be the best advocate is to really be an informed advocate. And so this may be review for some, but dementia is a general term for a progressive decline in cognitive abilities that interfere with activities of daily living. So dementia is an umbrella term. Alzheimer's disease is one specific cause or type of dementia. So when we say a decline in cognitive abilities, what are we talking about? We're talking not just about memory, which is what we often think of when we hear the word dementia or Alzheimer's, but in addition to memory, there may be changes in attention, language, ability to communicate or to understand what others are saying, visual, spatial, and perceptual functions, judging distances, executive functions like planning, problem solving, prioritizing, figuring out the steps in a process, and reasoning abilities, logic, judgment, things of that nature. So you may see changes in any of these areas. And for some people, memory may not be the most prominent changes. But what's key to a dementia diagnosis is that these changes, these declines, are affecting activities of daily living. So when we say activities of daily living, we're talking about those tasks that a person needs to do to function day to day. So higher level functions in the medical field, we call those instrumental activities of daily living. Things like driving, running errands, grocery shopping, household chores, keeping track of housekeeping, keeping the house in order, managing finances and medication. These are higher level activities of daily living. We see these affected first for people with dementia. And then as the condition progresses, we often do see an impact on personal activities of daily living. So more basic day-to-day tasks, things like dressing, bathing, managing one's personal grooming and hygiene, toileting and eating. So again, when we think about dementia, any disease that's causing dementia, that's causing a cognitive decline, is a disease that's affecting the brain. And the brain controls everything that we do. So it's much more than just memory. Depending where the damage is in the brain is going to determine what symptoms you are seeing in your loved one. And so if the damage is in the frontal lobe of the brain, you may be seeing changes in their ability to plan and problem solve, or in their ability to act appropriately in public, in their judgment. Whereas if the changes are primarily in the occipital lobe, in the back of the brain, you may see more changes in their visuospatial perception. Maybe they go to pour a cup of coffee and they pour it on the counter instead of in the mug, or they're trying to drive and they can't seem to stay in their lane. So any of these changes can be indicative of a dementia. It's important to note that there are potentially reversible causes of cognitive decline. So things like changes in mood, mental health disorders like severe depression, sleep disturbance. If someone's not sleeping well, they may not be thinking clearly or making good decisions or remembering. Other metabolic disorders, vitamin deficiencies, infections, tumors, and alcohol abuse can all look like dementia. But these conditions on this screen are potentially treatable or manageable, and with the appropriate care and first detection and then care, the cognitive changes may be able to be reversed. And so this is really critical to know when thinking about seeking medical care for cognitive or thinking changes. So again, dementia is an umbrella term. So if we set aside those reversible causes of cognitive change, there are dozens of types of dementia. Alzheimer's disease is the most common, and that's why many times we use the words interchangeably. Alzheimer's and dementia. But Alzheimer's is one specific type of dementia. It's the type where we see plaques and tangles in the brain, and it's the type where most often the hallmark symptom is short-term memory loss. But there are many other types of dementia. This is a reason why it's important to seek a diagnosis and be cared for by a specialist potentially, because they may detect that there is a different type of dementia going on other than Alzheimer's, and that may change the treatment plan and may change how they educate you as the caregiver and the patient about what to expect as the condition progresses. So again, dementia is progressive. Any of the dementias on the previous screen under that umbrella are progressive conditions. Before someone develops a dementia, before those declines in thinking start to impact or interfere with daily functioning, they may have what we call a mild cognitive impairment. So this would be when we see changes in thinking that perhaps the individual themselves notices those changes or their family notices. These changes might be picked up on testing, but they're not interfering with functioning. And so we would call that condition a mild cognitive impairment. About 15% of people with mild cognitive impairment progress to having dementia each subsequent year. So it is a risk factor for developing dementia, but not everyone with mild cognitive impairment will develop dementia. So when we talk about dementia, and this could be a whole presentation in and of itself, but just to have a basic understanding of what progression looks like, and this is most typically a progression for Alzheimer's disease because it is the most common form of dementia. But I will say that as any dementia progresses, they look more alike. So it's really in the early stages where we see a difference between, for example, Alzheimer's disease, where most often the changes are in memory early on, versus, for example, behavioral variant frontotemporal dementia, where the early changes are usually in behavior, socially appropriate behavior, or judgment. As those conditions progress, they look more and more like each other because they are affecting more parts of the brain. And so as the person becomes more impaired, their presentation looks more similar to other dementias. But in Alzheimer's disease, in the early stages, we typically see a decline in planning and problem solving. So that might lead to difficulty doing things like planning out a meal plan, planning a dinner, making it to appointments on time. We often see memory loss for recent events, for words, difficulty with word finding, and trouble learning new information because it's not necessarily being recorded. And then difficulty with those higher level tasks, those instrumental activities of daily living, like managing money or driving, managing medications. That often happens in the early stages. By the middle stages of Alzheimer's disease and often other dementias as well, we often see a disorientation, so not recognizing one's surroundings or being confused about what time of year it is or what the day of the week is. We might see memory loss for personal information, not being able to identify, who one's relatives are or one's own birth date. And then difficulty with those more basic tasks start in the middle stages. So trouble with dressing, showering, taking care of one's personal hygiene and body. And then as the diseases progress to the late stages, and I know this can be difficult for family members and certainly for people diagnosed to hear, the conditions do start to impact really basic human functions, including verbal communication, the ability to talk and carry on a conversation, basic physical abilities like walking, and in the very late stages, swallowing. And individuals do become vulnerable to infections and pneumonia because of these physical difficulties. So I share this, despite it being difficult to hear, because knowing what to anticipate, hopefully helps you know what questions to ask and how to be prepared. It is really critical to note that most dementias, with rare exceptions, most dementias progress gradually. When I say gradually, I'm talking about a number of years. So we do not expect someone to go from the early stages to the late stages within a number of months or a single year or two. We really expect this to be a several-year process. So it's a gradual change. And it's critical in your role as an advocate or caregiver to know that sudden changes, whether they're in thinking, in behavior, in mood, or in functioning, sudden changes are always a reason to call the healthcare provider. Because sudden changes might indicate one of those reversible causes of cognitive decline that we talked about earlier. So maybe your loved one has dementia, but they also have a urinary tract infection. That's the most common culprit. Or maybe they are also dehydrated, or they also have COVID. Any of these other conditions might cause a more acute or sudden change in their behavior. They might become agitated, or they might become very passive or more disoriented, not recognizing people that they usually recognize. And those can be the first signs that there's an infection or a virus that needs treatment. And with treatment, your loved one might return back to kind of what their recent baseline has been. So sudden change, absolutely call the healthcare provider. So at the end of each section, I do have some resources here for you. And there are links for some disease-specific organizations here. There are helpline numbers. Notably, the Alzheimer's Association does have a 24-hour helpline. So you can always kind of bounce off of a professional what the situation is that you're dealing with and get some guidance about how do I best advocate? Who do I need to call next? Is it the doctor? Is it the social worker? Is this something that requires a higher level of care? So there are plenty of helpline numbers here. There's also a couple of really good general books on caring for a person with dementia. So I'm going to move on to advanced care planning. And we often think about advanced care planning involving end of life. Advanced care planning usually is about care wishes for the end of life. But I'm talking about it now at the relative beginning of this presentation because it is never too early to start planning. But it can become too late, especially when we're talking about dementias that are progressive, that lead to a person not being able to, at some point, communicate or process complex information. It can become too late for them to put in place legal documents and healthcare planning. But it never is too early to have these conversations. So when we talk about advanced care planning, we're thinking about things like power of attorney. In Illinois, we have two different types of power of attorney. One is for healthcare, and one is for property. It's called property in Illinois, whether or not you own property. That's your power of attorney essentially for your finances. these power of attorney documents appoint an agent, a person who will carry out the wishes of the individual. The role of the agent is not to make their own decisions, but to execute the wishes of the person that they're caring for. And we'll talk a little more about that as we go on to the next slides. If there are no power of attorney documents, or if they're not valid documents, or there are arguments, maybe there are two conflicting documents, that is when a guardian may need to be appointed. A guardian takes complete responsibility for an individual, is appointed by the court, and the guardian must report back to a judge about all of their care decisions for an individual who is lacking capacity, the capacity to make their own decisions. The purpose of putting those powers of attorney in place early is to avoid guardianship. Guardianship is a costly process. It is a lengthy process. It can be stressful because it does involve court proceedings and can be contested. Maybe one person wants to be guardian and someone else thinks they would be a better guardian, and it can become a legal battle. So this is the reason to put those power of attorney documents in place early, while the person with dementia still is able to understand that who they are choosing and what they are choosing them, the role they are choosing them for. Advance directives are documents that can further guide the power of attorney for healthcare regarding the individual's specific wishes about what types of medical interventions they do or don't want, should they have a life-threatening condition. So some helpful tips for advanced care planning. Again, it's important to engage a person that you see having cognitive changes, engage them in planning early on when they are able to express and document their wishes. It's important to make sure that those who are named in the power of attorney have a copy of that document and have it easily accessible, not locked away in a safe deposit box, but somewhere they can pull it out if they have to call the paramedics. It's critical to have a successor or backup agent for both power of attorney for healthcare and for property, so that there is someone else who can make decisions if that primary agent is hospitalized, is out of the country, or for some other reason is unable to act. The power of attorney for healthcare in particular should be shared with the healthcare provider. Here at Advocate, we will scan those into someone's medical record, and that facilitates that agent being able to communicate with healthcare providers and make decisions on behalf of the patient in the future. It is also important when choosing an agent that the individual who is experiencing cognitive impairment, or even if they're not, the individual choosing an agent talks about what their wishes are. For example, they do not want a feeding tube, perhaps, or they do not want CPR. They need to make sure that the person who is their agent is comfortable and willing to carry out those decisions if they're called upon in their role as agent. And then in terms of planning legally and financially for long-term care, it's important to find out early on if your loved one has what their health insurance is, and also whether or not they have any long-term care insurance. And we'll talk more about that in a bit. But following are a couple examples of documents. These are guides from the Conversation Project, which you can find online, that help walk people through some questions to help them think about and communicate with their agent what matters to them with respect to their health care. You can only advocate for your loved one if you know what it is they want. And so by having these conversations, and even if your loved one is past the stage of being able to have these conversations, by considering, what did a good day look like for them when they were 50 or 60 and healthy? Or, how did they deal with health issues in the past? Was it something that they wanted to learn as much as they could about it? Or did they kind of put their head in the sand and just, want the doctor to take care of things? These are questions that can help you to provide the kind of care that your loved one would want. The Conversation Project does have a booklet specifically for caregivers of people with Alzheimer's and other forms of dementia. And this is just one sample page where they have these where I stand scales to help someone pick kind of where they are on a spectrum of where they want to be at the end of life or how they want to be cared for at different points in their disease process. So here are the resources for advanced care planning, that Conversation Project that I showed you examples of. That's that first link. 5 Wishes is another document you may have heard of that can help document specific end-of-life wishes. The Illinois Department on Aging does have the statutory short forms for power of attorney for healthcare and property linked on their website. You do not need an attorney in order to complete these documents. However, if the person that you're caring for is already cognitively impaired and there's question as to whether they understand the document and have the decisional capacity to sign it, then it is advisable to work with an attorney. And you can find one on the National Academy of Elder Law Attorneys website, which is linked here as well. So we're going to move on to kind of once you recognize that there's a problem and you're trying to get your loved one diagnosed and then work with that healthcare team. You can only advocate with the healthcare team once you can get them in the door. And oftentimes this is the greatest hurdle for families, is simply getting their loved one with cognitive impairment to see a provider. And why is that the case? Because dementia is the elephant in the room. There is still, unfortunately, stigma and shame associated with having memory loss or other cognitive changes. And oftentimes people don't want to talk about it. The patient themselves may also not recognize or see their own symptoms. They may forget that they had forgotten. They forget that they had a conversation yesterday, and so they don't believe that they've forgotten because it's just not there. It hasn't been recorded. And so sometimes you as the family member may be Alan, the one that the elephant is sitting on, who's the only one prepared to acknowledge the elephant in the room. Because maybe you're the one who lives next door to mom whose smoke alarm went off because she left her burgers on the stove too long. And so that first job as a caregiver of simply getting your loved one in the door of a healthcare provider's office is often the hardest. So how do you do this? And this can relate not only for that first visit, but for subsequent visits as well. So how to encourage someone that you see having cognitive difficulty, how to encourage them to go see a healthcare provider. I think most importantly, you need to decrease the threat. So you can explain, look, I'm concerned about your memory. And, I learned there are lots of other health conditions or a lot of health issues or vitamin deficiencies or things of that nature that can contribute to memory changes. So let's go and see if there's an easy fix for this. You can decrease the threat also by stressing that there are benefits to early diagnosis, that knowing what we're dealing with can help us to find the right treatment plan, find the right support services, and be prepared for the future. And if you are caring for someone who really does not recognize at all that they are having cognitive changes, try to focus just on their general well-being. They're aging, they're more frail, or you want them to be able to stay active and independent, and they should have a checkup. Whenever you can, it's helpful to get yourself out of the role of the bad guy, which might mean making their primary care physician the bad guy. Many primary care physicians will agree to this. They're going to be the one to make the referral to say, look, I want you to see a specialist. I'm concerned. I need to make sure I'm doing my due diligence. And in that way, they can sort of be the bad guy rather than you saying, I think there's a problem here and getting into conflict with your loved one. So how do you get started? Again, that primary care physician is a really good starting point because Medicare provides a Medicare annual wellness visit. It's a benefit of the Affordable Care Act. Beneficiaries are entitled to this yearly exam, and a cognitive assessment should be included in that exam. It is not always. And not everyone takes advantage. As you can see in these statistics, in 2016, only 19% of eligible beneficiaries took advantage of their Medicare annual wellness visit. That is a free covered service that people are not utilizing. But if they go in, you can ask for cognitive evaluation because it should be part of that annual exam. So when you have noticed changes and you're bringing these either to the primary care physician or to a specialist, the healthcare provider can needs you, the caregiver, as much as you need them. So they need information from you about when the changes began, what types of changes you're seeing. So it's important to have examples, not just say, my husband's been forgetful, but is he forgetting appointments or is he forgetting to take medications? Are you calling it forgetful, but he doesn't know what day it is, and maybe it's more of a disorientation. You don't need to know the technical words that the physician might use to describe their symptoms, but it is very helpful if you can describe in more detail what is going on, rather than just using vague words like he's forgetful or there's memory loss. How long has that been going on? Has it worsened over time? And if so, over what period of time? How has that affected functioning, like we talked about earlier? Are they having trouble driving or paying bills? And then it's important to, of course, like with any medical visit, provide family history, mental health history, any results of recent tests like brain scans, lab work, as well as a list of medications and including over-the-counter medications and vitamins or supplements. And this is from the United Hospital Fund. It is can be found online. It's a nice chart that can be used to capture all of the medications that are being taken and the dosages, as well as, supplements and vitamins and things of that nature. So once you get your loved one to a physician and you're trying to discuss the diagnosis, people often ask us, should I tell them that they have Alzheimer's, or are you going to tell them, or could you please not tell them that they have Alzheimer's? I will say that in the medical field at this point in time, it is generally accepted that patients should be informed of their diagnosis. We've kind of gone through the pendulum has swung as it did with cancer many years ago. People didn't used to be told directly that they had cancer. Maybe only their family was told. But at this point, there's a general consensus in healthcare that patients have a right to know of their own diagnosis. Now, it's a different story if they are told and then they forget, or they're told and they get really angry and they say, no, that's not true. You're wrong. You're a horrible doctor. We don't need to keep repeating it if they don't believe it or don't recognize it, but they do have a right to have the chance to take in that information. One way to get around this is to ask them beforehand, if your doctor diagnosed you with something progressive or with a chronic condition or with dementia, however you want to word it, would you want to be informed? If they can't tell you that, or you can't feel like you can't have that conversation, think about how they dealt with other health issues in the past. What did they say about their mom's health issues, or their dad's, or their other close family members, and how they would want to deal with the same if it happened to them? Think about their degree of understanding of what's going on and their degree of kind of self-awareness. So prepare in advance for how and when to have the discussion. Do you need support on hand? Do you want to ask the physician, is there a social worker or a psychologist or someone in the clinic who maybe we can talk with after we talk to you, the doctor, because the doctor might have a limited amount of time. And maybe you anticipate that your loved one is going to have a hard time accepting this news. Maybe they'll be depressed or anxious or have a lot of questions, and they might need more time than the doctor has. So ask who are the other support team members. To be an advocate for your loved one, it's really critical that you have the necessary documentation on file, such as a release of information, whether or not you are their agent under power of attorney. If there's a release of information signed, or if your loved one has given consent to the healthcare system that, yes, you can talk to my daughter, Danielle, then you'll be able to call and relay concerns and ask questions. Without a release or a verbal consent from your loved one, the healthcare team, unfortunately, their hands are going to be tied and they're going to say, I can't give you information. If your loved one is resistant to you being in the visits, I will say that most specialty clinics for dementia will have a policy that it is standard to have to ask for a family member to be there. So ask the office, is this standard practice? And if so, can you communicate that to my loved one? Find other ways to communicate with the healthcare team if it's too upsetting, if it causes conflict for you to talk about your loved one's symptoms in front of them. Provide those in writing or get access with their permission to their patient portal account so you can relay things electronically to the healthcare team. And then ask the provider not only about medications, but about therapies, about resources, and other supports that are available. Because unfortunately, medications have, and this is not a presentation about medications and treatment options, but they do have limited benefits. And so it's important that you know about other interventions for quality of life. So here are some resources related to diagnosis and after getting a diagnosis. Some of these are supportive services for people with a diagnosis. So patient-facing literature from the Alzheimer's Association, the National Council of Dementia Minds has groups for people diagnosed with dementia to come together and talk about their experiences. By Us, For Us guides are booklets written by people with memory loss, and some written by care partners. So these are some really excellent resources. And then the Family Caregiver Alliance has just loads of fact sheets for caregivers. Many of these are related to caring for someone with dementia. So moving on to when you recognize that some help is needed, that the person just isn't going to be okay at home on their own. So first of all, we often get the question, well, how do I know when help is needed at home? Or will you, the doctor, or you, the social worker, tell me when help is needed at home? And again, the truth is the doctor only knows as much as you tell the doctor, right? Or the nurse practitioner or the social worker. If they aren't making home visits, they don't know how your loved one is doing at home. They could make an educated guess, but they really are going to rely on you to share what you are seeing. So these are some signs of concern, signs that you would want to alert the healthcare provider to. You might see that healthcare provider every 6 months or every year, but maybe sooner than that, you notice a change in one of these areas. You notice that mom just isn't eating regularly, or she's starting to lose weight, or you realize she was supposed to refill her medication 2 months ago and still has a full bottle. So she must not be taking her pills on time. Or she just really isn't clean anymore. Her clothes have stains or her hair is disheveled. These are things that should be relayed to the healthcare team and that are flags that some additional assistance is needed at home. Other signs might be impaired judgment, perhaps going outside in short sleeves when it's 0 degrees outside, or letting solicitors into the home, things of that nature. So what are those home and community-based services that might be helpful when you do notice these signs? Non-medical home care is most often the type of home care that our patients with dementia need. So this is like homemaker or companion services, someone to help with day-to-day tasks that really are not healthcare tasks. They're not, wound care or other medical care, but they're more caring for a household, caring for an individual in terms of providing supervision and helping them kind of get through the day safely. Adult day services also provide some of this in a setting where the individual can participate in activities, socialize with others, and have kind of some structure to their day. And home delivered meals might be another service that could be helpful at home. That can also provide sort of a well-being check when they come and drop off the meal. They get to know the people that they're bringing meals to and, hi, Mrs. Jones, you're looking kind of tired today. And maybe they report that back to their supervisor. So this can be another way to have another set of eyes on the situation. It's important to know that these services are not covered by Medicare or traditional health insurance. This is a very common myth that Medicare covers these services for home care or daycare. It does not. There are very rare Medicare Advantage plans that might. Most often, people are either paying out of pocket or they're using what's called a Medicaid waiver program for folks with very limited financial means. In Illinois, this is called the Community Care Program. So to access home and community-based services, here are some resources where you could locate services. And notably, the Illinois Department on Aging is the place to call if you think that your loved one might qualify for services to be paid for by the state. So advocating during hospitalizations, just a few key pointers here. If you are calling 911, whether it is for a change in behavior, which sometimes needs sometimes 911 first responders are needed if a person with dementia has become aggressive or is putting themselves or someone else in danger, or if you're calling for a medical reason, it's really critical that you communicate to the dispatcher that your loved one has dementia so that they know coming in that they need to also talk to a family member, not just to the patient, and they understand coming in that there may be behavior that seems unusual or may even be in some cases aggressive. It's important that you or someone else is present for any hospitalization to make it very clear what your loved one's baseline is. The medical team in the hospital isn't going to know that mom always knows what day it is and who her children are, unless you tell them. Inquire in advance about the potential effects on their thinking of any planned surgery. So is general anesthesia being used? Is there one that is safer than another for someone with dementia? Do we anticipate that this procedure will affect their thinking? You may not get an exact answer, but it will help you kind of consider the costs and benefits. Couple other points. Ask for delirium prevention protocols. Essentially, this means that you want the staff in the hospital to be alerted to help your loved one avoid kind of that heightened confusion and disorientation that can come from being hospitalized. So you want to make sure they're getting your loved one up and walking as soon as they can. You want to make sure they're providing fluids regularly. They're providing all of the sensory tools that they need, glasses, hearing aids, to help them stay oriented as much as possible. It's important that you know whether your loved one is being admitted for observation, which is covered differently by insurance than an admission. And then what's really key is that if you don't feel that it is safe for your loved one to come home, it's important that that is communicated clearly to the medical team, that this discharge plan is unsafe for X, Y, and Z reasons. So a safe discharge plan should include communication from the medical team about, what to expect, what care will be needed when your loved one gets home, what are the changes in their medications, what's the follow-up plan. If they haven't provided you this bridge, which hopefully they have, but it doesn't always happen as thoroughly as we would like, it's important to ask for it. This is a worksheet. This comes from that Family Caregiver Alliance, and it walks through the different types of tasks that after a hospitalization, someone might need help with. And using a worksheet like this can help you think through which of these areas does my loved one need assistance with after this hospital stay, and which of these things can I help with, or am I going to have to hire someone to help with them? So a few resources here during a hospital stay and even in an outpatient setting. Health systems do have ethics committees. You can request an ethics consultation if you feel that there is a conflict around the type of care that's been received, if you feel that the healthcare team is not hearing you about safety concerns or is not recognizing who is the surrogate or the decision maker, you can request an ethics consultation. This Is Not My Mom is a very cool website. I, for some reason, can't access sound on my work computer to hear the videos, but it has a video of a woman who is kind of in a delirium. She's very disoriented in the hospital, and family is trying to convey to the healthcare staff, this is not my mom. This is not what she looked like, a week ago at home. And you need to do something to figure out what is going on here. So there's helpful information about delirium on that website. So I'm going to go through the next slides fairly quickly because I would love to leave time for questions. But some signs that a higher level of care might be needed beyond those home care services that we talked about. These signs may be with your signs that your loved one shows, that they're depressed or they're understimulated, they're just sitting around all day. It may be signs that you see in the home environment itself, that there are fall hazards that can't be fixed, that the home is just too big and the person's getting confused or lost or just not able to manage keeping it, clean and orderly. Maybe you've tried home care and your loved one sends the home care team away, or they are at a point where maybe they have other medical conditions and they really require two people at a time to physically assist them. Maybe someone needs to hold on to them while they're getting dressed and another person needs to help them put their shirt on. And it's just not affordable to hire two people at a time. These are all signs that a higher level of care or residential care might be needed. And really critical is, how is that primary caregiver doing, whether it's the spouse or the adult child. If they are getting sick from providing care, if they've started falling when they're trying to help the family member into the bath, or they're getting injured providing care, or they're having panic attacks because they're so stressed juggling care and work, you're not going to be able to provide adequate care if that's the case, if you're not able to care for yourself. So again, important to know that Medicare does not pay for long-term care. So important to be prepared either to pay out of pocket or to apply for Medicaid. The only other situation would be if someone has long-term care insurance, and there's some questions here to ask of the plan if your loved one does have long-term care insurance. Medicaid in Illinois will pay for supportive living facilities, which are essentially affordable assisted living facilities. and they'll pay for skilled nursing facilities. They won't pay for assisted living or independent living. These are the only levels of care. And most memory care facilities are licensed as assisted living and therefore do not take Medicaid. So a few key points about looking into residential care. Again, like with advanced care planning, it's never too soon to start. It is really important to make sure you're comparing apples to apples, that if you're looking at one memory care assisted living community and one nursing home with a memory care unit, it's important to know that these are not the same level of care. I'm going to provide you with, on the next slide, a checklist that you can use if you're comparing communities to each other. And a key question that I always advise people to ask up front is, what symptoms or conditions or changes would require my loved one to move out of this facility to another level of care? You don't want to be blindsided by that. So this is one example from Medicare's website of a checklist that can be used to compare facilities. The Illinois Citizens for Better Care also has a checklist, and that website is listed later. Again, important to work with the healthcare team to present something like a move, whether it's saying this is, the physician is saying that you need to be in this setting, or, the doctor ordered this, or the doctor wants you to have this therapy. You need an ally in this. It's not a one person. You can't have it all on your shoulders, that you're making the decision for your loved one. And then once you've chosen a facility, you now have a broader support team. You have the staff there. And so lean on them, coordinate with them for how to minimize stress for your loved one, how to make that moving day, something that is more calm and enjoyable, and less triggering for your loved one. You can do that by bringing items from home, by educating the staff about, your person's life story and what they like and don't like, and how you've cared for them over the years. Build relationships with those staff and understand where you can turn. How frequently are there care plan meetings? Who's the appropriate point person if I have a concern about X, Y, or Z? So here's one example of a document that can be used to relay information about your loved one to a residential care facility. Here are some resources for finding a facility and preparing for a move. And briefly here, I just want to comment on palliative and hospice care. Really, most care that we provide for people with dementia is palliative care, which means essentially it's supportive care, it's comfort care. We can provide life-prolonging care and palliative or comfort care at the same time. So providing comfort care does not mean that we're giving up on someone or letting them die. It simply means that we are also prioritizing their comfort, their quality of life, and their wishes. And these are things that you do not need to wait for the healthcare provider to offer. You can ask, would it be appropriate for you to place a palliative care order at this time? Or should we start talking about hospice care, which is care at the end of life? Should we be having this conversation now? You do need a physician's order, but you don't have to wait for them to bring this up. And here are some resources for having some of these conversations. So with that, I know are at the top of the hour, but if there are questions, I'm happy to stay for a few minutes to take those. And thank you so much for having me.